Morning, depending on where you're joining us from. I'm Kristen Hitchcock. I'm the Administrative Director of the Healthcare Initiative at Chicago Booth, and I am delighted to welcome you to today's event, Improving the U.S. Healthcare System, the Better Care Plan. So our vision at the Healthcare Initiative is to see the Chicago approach of data-driven analysis and evidence-based decision-making widely implemented throughout the global healthcare industry. And through supporting events like this, we aim to foster dialogue and collaboration among thought leaders, practitioners, policymakers to address the fundamental business challenges in healthcare. So we're honored to host today's presentation and discussion featuring two distinguished alumni of the former hospital administration program at the School of Business, Stephen Shortell and Ken Kaufman. I'd like to start by introducing Ken as our moderator for this event, and then I'll turn over the session and I'll allow you, Ken, to introduce our featured speaker. A quick note, though, on logistics before I do so. Our guests here today, you're invited to enter your questions into the Q&A function at the bottom of your Zoom screen, or share insights that you have into the chat during the event. And then after the main presentation, we'll have plenty of time for questions received from the audience. So to start, please join me in welcoming Ken Kaufman. Ken is the founder, managing director, and chair of Kaufman Hall, which is a leading consultancy firm specializing in healthcare strategy, finance, and capital planning, and is now a part of the Vizient family of companies. With nearly 5 decades of experience, Ken has advised a wide range of healthcare organizations, including community hospitals, academic medical centers, and national health systems. He's a recognized authority on the healthcare industry and change in the industry, having delivered almost 600 presentations and authored or co-authored 8 books. And I know at the Healthcare Initiative, we're grateful for Ken's insights on the industry. He's been working with our Healthcare Analytics Lab most recently on health system access issues. And I think that kind of intimate knowledge of those on-the-ground challenges nationwide makes him a great choice of moderator for today's event. So welcome, Ken.
Great. Thank you, Kristen. I should add that I'm Booth 76 and very proud of it. And I'm really pleased to be hosting this webinar this afternoon. I should also add that, amazingly enough, Steve Shortell and I have known each other since 1974, which seems almost impossible, but it's true. So without further ado, I'd like to introduce Professor Shortell. He is the Blue Cross of California Distinguished Professor of Health Policy and Management Emeritus, Dean Emeritus, and Professor of the Graduate School at the School of Public Health and Haas School of Business at the University of California, Berkeley. He served as Dean of the School of Public Health from 2002 to 2013, and he is the founding director of the Center for Healthcare Organizational and Innovation Research and co-founding director of the Center for Lean Engagement and Research in Healthcare. Professor Shortell is the author or co-author of nearly 400 peer-reviewed articles and 10 books, and Dr. Shortell and his colleagues have received numerous awards for their research, including the Baxter Allegiance Graham Prize for Innovative Contributions to Health Services, the Gold Medal Award from the American College of Healthcare Executives, the Distinguished Scholar Award from Academy Health, and the AHA-HRET Trust Visionary Leadership Award, among others. He was recently elected into the Modern Healthcare Hall of Fame and is recipient of the Welsh Rose Award for Distinguished Service to Academic Public Health. His research examines the formation and performance of integrated delivery systems, the organizational factors associated with quality and outcomes of care, and factors that influence the adoption of evidence-based processes for treating patients with chronic illness. He is currently conducting research on value-based healthcare delivery models and on lean management applications in healthcare. He is an elected member of the National Academy of Medicine and serves as an advisor to many organizations committed to improving health and healthcare in the United States. Professor Shortell received his PhD in the behavioral sciences from the University of Chicago Booth School of Business in 1972 and he was assistant professor and acting director of the program and hospital administration from 1972 to 1974. And so now turning the podium over to Professor Stephen Shortell, Improving the U.S. Healthcare System, the Better Care Plan. Steve?
Sure. Thank you, Ken, for that comprehensive introduction. And just a little bit of background and context, as Ken mentioned, I'm actually booth maybe 3 times, booth 70 for the MBA, and then 72 where the PhD, and then on the faculty in 74. And I had the honor of, well, George Schultz was dean at one point in time, and then Sidney Davidson took over from George. And I worked with both of them in various capacities. And just very proud of all our alums and graduates over the years. Ken is one of them. Ken and I overlapped 1 year at least before I left Booth to go out to the University of Washington for a while. And I also want to commend Matt and Dan and Kristen for their leadership in beginning to revitalize the university's interest, or certainly the Booth School interest in the healthcare sector. I think it's terrific, and anything I can do to forward that, I'm happy to do. So with that, a little bit of background. Kristen's going to advance the slides. If we go to the next slide, Kristen, gives you an outline of where we're headed. And what I want to do is just say that a lot of what I'm going to present is not just my work or thinking, but I'm a member of a group of 8 of us. I'll talk about them later on, but I want to save time for questions. We're the Better Care Health Policy Group in the lower right-hand corner. And this is the outline I'm pretty much going to follow. I'll say more about this group and the impact we might be having as we go forward. So the next slide, the next 7 or 8 slides are things we may know, but maybe just underscore them quickly. We simply underperform. We do not have a very good healthcare system in the United States, okay? And access to care, administrative efficiency, equity, outcomes, overall ranking. One example, premature excess death rate in the United States is over twice that of the United Kingdom. This is a recent Commonwealth Fund report out of New York that does studies of OECD countries, about 12 or 14 of them. And on almost all measures, the US system is in the bottom quartile, if not near the very bottom. So if we go to the next slide, this is some other statistics on high variability system. Maternal mortality, 23.8 in the US, 7 per 100K births in France. States, look at Arkansas, 49.5 per 100. California, 11.7. We rank 33rd out of 36 industrialized countries for highest infant mortality rate, 95.4. Hospital mortality within the same city. This study was done in New York, can vary by 3 to 1 depending on what hospital you get admitted to. And hospital complications can vary by 6 to 1. In all of this, I put the sources, the evidence base at the bottom if you want to explore them further. If we go to the next slide, we're high cost. We know this. So I've just shown you we're not getting much for all this money we're pouring in. And it's estimated that about 935 billion of this is wasteful. And I've broken it down here using data from Schrank et al. Study back in 2019. This study should be done again to update the numbers. Low value care, etc., 355 billion. Administrative complexity, 261. Prices, 233. A lot of people think, well, it's just the prices. It's not. It is the prices, but it's some other things too. Fraud and abuse is 84 billion. Go to the next slide. So some causes of this. Diagnostic errors, and myself and a couple colleagues are working on this. I can talk more about it in the Q&A. Nearly 800,000 people die or are permanently disabled each year due to diagnostic errors. Of those, if you want to parse it, 400 are about deaths and another 400,000 are disabilities. Poor coordination of care, unnecessary low-value care, hospital-acquired infections, medication errors, insufficient oversight and accountability. And of course, the social determinants of health play a big role as well. Next slide. So there's an old adage, okay, we don't pretend to be novel, anything I've said so far. Everything that needs to be said about this topic has been said, but not everyone has said it. It reminds me of faculty member meetings at Berkeley, right? Where everybody has to have their say, even though it may be the 5th time that somebody has said something, but not that person. Maybe it's different at Booth. I don't know. If we go to the next slide, what we see here is what I'm referring to. I'm not going to go through all of this, but back in 1932, the Committee on the Costs of Medical Care, Michael Davis, who was involved in helping to establish the University of Chicago program, was involved in this committee. And as early as 1932, nearly a century ago, they said probably the best way of delivering health care in the United States is through prepaid medical group practice. Kaiser Permanente, of course, picked up on that. Almost no one else did until much later on, and we're still working on that today. Go to 2001, upper right-hand corner there. I was privileged to serve on this committee with Don Berwick and others, Crossing the Quality Chasm. It was a seminal report documenting a lot of things I've already talked about. And then there's some other things here, as you see, as well, that I and others have participated in. So a lot of this is not new. If we go to the next slide. So think about this. If home building were like healthcare, carpenters, electricians, plumbers would each work with different blueprints with very little coordination. If airline travel were like healthcare, each pilot would be free to develop his or her own pre-flight safety check or not to perform one at all. And what some others think, Robbie Pearl headed up the Permanente Medical Group. He now does a lot of blog and writes books. Over the past 5 years, American medical care has produced a losing record. Yes, we have developed new drugs and surgical breakthroughs have made headlines in CRISPR and so on. But the deeper, more systemic failures have rarely penetrated the news media. If our nation wants to make the next 5 years better and healthier than the last 5 years, elected officials and healthcare leaders will need to make major improvements, not just incremental. So with that as an anchor, let's go to the next slide. And these are our pillars of the Better Care Plan. We need to change how we provide care. We need to become much more proactive, not reactive. Relational relationships between primary care and their patients, not one-off fee-for-service transactions. Continuous improvement mindset, where we really study access to care and what the barriers are and how we eliminate them. And we'll say more about that. I know Booth is doing some research on that. Dan Edelman, for example, I believe. Risk-adjusted prospective payments. I'll say a lot about that. Change how we pay for care to create the right incentives for the things in the left-hand box. And then much more accountability and transparency in terms of reporting patient safety and quality of care outcome reporting. And what we did then in the paper, and I can cite the paper later on, next slide, is we broke it down into these design principles. In the interest of time, I'm not going to talk about all of them, but that one in the upper left-hand corner has a lot of words that could be expanded. Integrated, coordinated, team-based. Technology-enabled digital health, electronic health records, AI applications, patient-centered primary care, big time. And then you can see the others there, risk-adjusted payment to make that work, access, patient access to records, et cetera, and competition based on patient quality, access, and price, the whole bundle. So in the paper, which I'll make available, we expand on these, and I'll also expand on them in the remaining slides. So if we go to the next slide, thanks, Kristen. So I'll just say a little bit about team-based care, because many of us now, as we age, we have multiple chronic illnesses, and it requires teams to do it. And with the shortage of primary care physicians, we need more done by nurses, by community health workers. A lot of these problems and issues can be handled and leave physicians what they need to do for the complex cases. So these are advantages of team-based care. Some of the evidence base, patients experiencing care with poor teamwork, 5 times more likely to have complications or death from surgery. That's an inpatient team-based compared to patients with better functioning teams. A review of 31 studies found well-functioning teams performed better on multiple performance measures, including postoperative complications and bloodstream infections. And many new innovative care models are based on team-based care. Next slide. So these are some of the criteria. Not going to go through all of them. All of these slides will be made available to you. But number 6, use every team member's competency to the fullest, practicing at top of license. One of our policy recommendations is to break down the differences by state and licensing laws and create a national, at least floor of practice for all healthcare providers. And if some states want to be more rigorous or whatever, that's fine. But let's restrict, the barriers to having more people practicing at top of license. And 7 is really key, using predictive analytics, AI, to identify those high-risk patients, not just predictive AI, but generative AI, and allocate resources based on need and patient preferences, and really focusing on eliminating disparities and inequities in care. So these are some team-based criteria. If we go to the next slide, this is interesting in terms of the evidence base and, Booth's whole culture. What's the evidence? What's the evidence for that? This is a review of a number of studies from diabetes care. Some were randomized, some were not. And what you see here is what favors the intervention. And you see the confidence levels there as well. The most important one in these trials was what I've been talking about. Team-based changes in how care is delivered, moving towards team-based care. As you see here, the difference in post-intervention blood sugar levels, keeping it in control. And this was for diabetes patients. And second most in 26 trials is case management. And then you go down the list from there. But all of them favor the intervention. But the top ones there are those team changes and case management. And if you really look at it, you can probably group some of the others underneath those top 2. But these studies broke them out to look at specific components. So this, I think, is pretty powerful. The journal article is there, Shojana, etc., in JAMA 2006, the effectiveness of these strategies. Go to the next slide. Those are some additional elements of team-based care. I'll just skip over them from now. Not that they're not important, but in the interest of time. If we go to the next slide. Okay, continuous quality improvement, operational excellence management system. Whether you call it lean, the Shingo principles, high reliability organization, or other, kinds of names for it. I and a colleague started a center here at Berkeley that's now nearly 10 years old, Center for Lean Engagement and Research in Healthcare. And we have an action learning lab where we work with about 6 health systems across the country, from Pennsylvania to California, Indiana's included. And we work with Catalysis, that's an educational quality improvement organization that works with leaders of our nation's hospitals around doing continuous improvement. These are some of the common elements: continuous learning culture, team and data-based, continuous PDSA cycles, right? Plan, do, study, act, plan, do, study, adjust, developing the problem-solving skills of everyone, decentralizing and realizing that those at the front line are best positioned to improve care. Alignment then at all levels of the organization, and then systems, excellent management systems, standardizing work, huddles, etc. So we've done a lot of research in this area. Happy to talk more about it if we have time. If we go to the next slide, here's the evidence of impact. We did a rather seminal study that was published in the Joint Commission Journal a few years ago. Working with the American Hospital Association, we collected data from 1,200 hospitals where we operationalized measures of lean management, or related to that. I'll just use that term for shorthand now. And this is not causal. It's not a randomized study, but we found consistent positive associations between those hospitals that scored really high on enterprise-wide implementation of continuous quality improvement methods and principles and culture, and higher patient experience scores, all of these statistically significant, lower adjusted inpatient expense per admission, controlling for a lot of other variables, lower 30-day unplanned readmission rates, and less use of low-value care without a negative impact on overall mortality. The citation is there. We can talk more about that. We're now in the process of selecting funding. If anybody has some suggestions to update that work, to look at changes now over time and update post-COVID, what's happening in 2025. We're hopeful we'll secure some of that funding to do the follow-on study. Significant declines in heart attack mortality. That's not our study, that's Health Grades and University of Massachusetts Medical Center, where they've really implemented this way of managing. Improved patient flow during the pandemic. Okay, New England Journal of Medicine article in 2020. And both Dr. Lucy Xenophon and Dr. John Toussaint are members of this Better Care Health Policy Group. And they've done some interesting work on patient flow. Marked decline in sepsis death rates. This is Kaiser's experience, from 20% to 3%. Okay, took them 2 or 3 years to do it. They constantly iterated before they finally got it down to 3%, and they've been holding it at that. We find many other hospitals say, hey, we do everything we can to prevent these things. Some are just inevitable. And, the culture you need is to say, no, let's study this. We have patients dying from this. We can do better than that. So this is some of the evidence of the impact of what I'll call these operational excellence management systems. If we go to the next slide. So risk-adjusted prospective payment per member per month creates health budgets for provider organizations. If you have your budget up front, you have every incentive now to keep your insured people well and continuously innovating to improve care. If you need to hire community health workers, you make these changes, you have the revenue to do that. And it's a predictable revenue stream. Hospitals and medical groups under COVID, who had more of their money under risk-adjusted prospective payment simply did better financially. There's just no question about that. They weren't relying on the fee-for-service. People aren't showing up. I can't charge for it. I can't bill for it, etc. And so our group is working with a lot of players to move all payers, all the commercial payers and plans, to risk-adjusted prospective payments. LAND 3 and 4, Learning Action Network 3 and 4, downside risk adjustment, with quality gates and adjustments and so on to mitigate against stinting on care. So this is a big part of our work. The next slide. So the evidence here, organizations that have more risk-adjusted prospective payment have generally higher clinical quality of care and lower total cost of care. Medicare Advantage uses risk-adjusted prospective payment to pay providers, and their clinical quality performance is higher for these patients than those in traditional Medicare. There are issues with Medicare Advantage, as you probably know, in terms of risk adjustment and coding and all that, but those are beginning to be addressed. If we continue on with evidence of impact, here comes from California's experience, where we've been working on this for a number of years. I'm on the board of the Integrated Healthcare Association. So what this slide shows on the x-axis down there is no risk, fee-for-service, and then it goes to professional risk only, which is ambulatory care but not hospital, to global risk, which is the whole shebang, and then dual risk, some of both. And what you see here on the y-axis is the risk-adjusted total cost of care. And it's highest with fee-for-service and lowest under global and dual. If you go to the next slide, how about clinical quality? Okay, here you go from left to right better. There's a standardized clinical quality measure that uses a lot of NCQA measures and a lot that others use. And in California, we're now aligning all payers around this measure. In fact, I have another Zoom call following this and a meeting down in Southern California tomorrow that's dealing with some of these things. And what you see is global risk, highest quality up there, score of 59. Dual risk also quite high. So the evidence is really quite, I'm not going to say overwhelming, but in the direction consistently that this is a better way to deliver healthcare, quality, and also in terms of containing the rate of growth in costs or cost performance. If you go to the next slide, this is the Medi-Cal measurement set, and it's the same one I showed you on the previous slide where you added up to give the overall clinical quality score. We're getting into the weeds here. It may not be of interest to you, but it's some of the standard screening, and then diabetes care, really important, blood sugar and so forth, imaging, all-cause readmissions, and then total cost of care. So these are the measures that we use in the Medicaid program in California, and a number of other states use ones similar to this as well. If we go to the next slide, and again, thinking ahead now, setting goals, and this is what we're working on, is the Office of Healthcare Affordability in California is setting spending growth targets beginning this coming year. And here are some of the targets in terms of moving to these risk-adjusted prospective payment models, what's called the Land Action Network up there, Healthcare Plan Land Action Network 3 and 4. So for the commercials, and you can read as well as I, goes from 65% of payments should be under that category 3 and 4, down to 95% by 9 years from now. Commercials, PPOs less, it's going to be harder to do. Medi-Cal 75%, Advantage should be nearly universal. So these are targets that have been set and are going to be tracked over time. There's about 9 or 10 other states doing not necessarily this, but are also setting spending growth targets that we're going to be following. Next slide. So this is just a summary. If you look today at what percent of U.S. healthcare payments are in these categories that I've talked about by the line of business, okay, all lines of business on the left, the commercials, the Advantage, the Medicaid, and we also have traditional Medicare here. I'm going to try to add these up for us a bit if I can. And what you see here is broken out. And my addition says that on the left, all lines of business, if you go down to 16.7%, right? And that is category 3A, 3B, and 4, eliminating 1 and 2, you have about 46% of all payments now are under some form of risk-based prospective payment. For the commercials, it comes out to 40%. For Medicare Advantage, 64%. Medicaid 44%, and then traditional Medicare 42%. And the rest is still fee for service, right? So we made progress, but it's slow, and this is where it currently stands. And we need to push it faster. If we go to the next slide, risk adjustment's important, area deprivation index can be used, social determinants, measure that, audited encounter data, absolutely. We can always improve risk adjustment. Next slide. Okay, let me move now to the sort of the last part of this. I think we're good on time. Patient safety and outcomes data reporting. So here we're saying define what will be measured, what risk-adjusted outcomes, and by race, ethnicity. And we've talked about some of those already. Some of us believe, others aren't sure, mandate reporting with national laws and regulations if after voluntary efforts we're not moving the needle. We've got to reduce the reporting burden, take advantage of artificial intelligence technology. Some of us are working with Epic, the largest electronic health record company in the world. They have over 200 million medical records, and they're developing a bunch of algorithms to be able to enable those hospitals and health systems that use Epic to reduce the reporting burden on infections and a bunch of other stuff. Test and refine. And then some of our group says that it also needs for patients easy to interpret and read, almost like numerical grades, like FICO credit scores that you get, for example, if there's a way of doing that. One thing we have here, I'll just pause a little bit. We have a potential experiment going between Epic and Leapfrog. Leapfrog does patient safety grade scores, gives hospitals grades A through D on their patient safety measures, and they now have about 300,000 300,000 hospitals that are voluntarily participating in that. And we're going to try to leverage that initiative. Next slide. So these are some things going on that we're supporting. You may know about these. There is the Bill 9377 to create a National Patient Safety Board. We don't know where that stands now. There was a report to the president, then Biden, on this. We have no idea where that may be going now. Next slide. So our idea is to certify those health plans and provider organizations that meet the Better Care Plan principles and criteria. We don't want to reinvent the wheel, build on already the certifications that exist or the special recognition programs, but let's get it lined up and expanded and using the same criteria, etc., so that employers, when they choose health plans, they have this information available to them on what the better plans and provider organization networks are. And we're thinking about what entity or entities that might do this. Next slide. Okay, recommendations to increase primary care capacity. Some of this is going on. I won't go through all of this. Notice the bottom one, though, that I mentioned earlier. We're really calling to develop a national healthcare profession licensing body to define common nationwide competency standards for professional practice. Nurse practitioners, physician assistants, pharmacists, other healthcare professionals to fully utilize their training in providing team-based care. And yes, we need to increase residency slots in rural areas, etc. Medical schools need to do more to teach these continuous improvement processes. It doesn't take long. Most medical students do not get exposure to this currently, or maybe residency is a good time to do that. So we have a bunch of recommendations around that. Next slide. And here's about risk-adjusted prospective payment, what we're really working on in these groups. And you can see them as well as I. Employers of 50 or more should offer at least one health plan to their employees based on the Better Care Plan design principles and criteria that we've discussed, right? Okay, and etc. Medicare should move all of Medicare to risk-adjusted prospective payment following the lead of the Medicare Advantage program. Hospitals and health systems should accept risk-adjusted prospective payments from all payers. This is really a challenge to crack. Hospitals now depend on filling the beds for their financial viability. And to move away from that requires a lot of discussion, negotiation, and so on as to, I've had people tell me, and Ken probably a lot more, yeah, I'll move to risk-adjusted prospective payment, but what's that figure going to be? Let's negotiate that. It takes into account that maybe we have a more severe case mix, we're academic medical center or whatever. We'll have no problem with an upfront budget, but it needs to be realistic enough that we can use those dollars to improve care and not get penalized by keeping people out of the hospital when in fact it may be marginal. They don't need to be there, but the incentive now is to put them there because I get a DRG hit. And by the way, if I discharge them too soon, they have to come back in, I get another hit. Maybe I get a penalty for a risk-adjusted readmission, but I also get another hit. So these are some things we're working on. Next slide. Yeah, this is the National Patient Safety and Health Outcomes Reporting. The second bullet, we think CMS, Dr. Oz, should establish a national committee convened by the National Quality Forum, and they're now part of the Joint Commission, and or the National Committee on Quality Assurance, Peggy O'Kane's group, or some entity, to define a small number of high priority clinical outcomes that can be captured electronically and reported on a daily basis, broken out by race, ethnicity, fed back, and used to continuously improve care and facilitate plan and provider organization comparisons. So you don't wait a year to get your score, etc. But it's more or less continuous. Not there yet for sure, but this project with between Epic and Leapfrog is one step in that direction. NQF, the next bullet, or similar entity should convene experts, and they do a lot of this now, to develop relevant, reliable, valid measures of diagnostic errors. Recommend how these can be identified and reported on by provider organization and clinical sites of care, and by race, ethnicity. So we're working on these, and the role for the Joint Commission in making sure the patient safety practices are being implemented, et cetera, et cetera. So this is a big area of our focus as well. The next slide. So implementation challenges. I'm going to begin to wind down. We'll have plenty of time for your Q&A here. We're not naive, as you'll see at the end with the other members of my colleagues. Only 2 of us are academics. All the rest have been in the trenches, so to speak, in the policy and practice world, like Ken and others. So we're well aware of the vested interests, the current business models that are getting rewarded for keeping things as they are. The long entrance fee-for-service payment system, we're still dealing with that. A lot of habits instilled in medical and healthcare professional education and training. High degree of variance across and within states, as I indicated earlier. And we know that a combination of policy carrots and sticks will be needed, and we're trying to work on the right combination of those. Those are some. I'm sure there's other implementation challenges as well. Next slide. So in conclusion here, and a couple more slides after this, all 3 pillars are needed. We need to change how we pay for care, deliver it, and are accountable for care delivered. We need to spread the current pockets of excellence, and there are some, throughout the country. And we know everyone deserves accessible, continuously improving is the key, continuously improving, equitable, and affordable care. In the next slide, these are our working groups. And so we're not an academic organization here that's just pontificating. We have these people engaged. We've had 2 summits in Washington, D.C., and we have active ongoing work groups that meet maybe every 5 or 6 weeks. So you know some of these, but if not, America's Community Health Plans represent all the health plans, the big ones. Association of Health Insurance Plans, some of the more not-for-profit health plans are represented. Everybody knows CMS, CMMI. Purchasers Business Group on Health, Elizabeth Mitchell, they're doing a lot of interesting experiments with employers. Healthcare Leadership Council is a multidisciplinary group of hospitals, health systems, pharmaceutical companies, and others. Dr. Jerry Penso heads up, Susan Denzer heads up America's Physician Groups, and they represent a lot of the medical groups in the country. And then AMGA is Dr. Jerry Penso, and that's the other one. They have about 400 or so members. There's a National Association of ACOs. Cliff Gauss headed that up. Rob Mechanic directs their research. They've been very involved. IHA, I've mentioned. Morgan Health, doing some interesting things. NCQA, Peggy O'Kane, Leapfrog, Leah Binder, Embold, Healthcare Transformation Task Force, Catalyst for Payment Reform, National Quality Forum, and EPIC has joined, among others. So these are the groups we're trying to nudge along. Next slide. So key messages: alignment across payers, better, more timely data generation and sharing, streamline quality measures, more patient-reported outcomes, PROs, electronically generated measures, continuous improvement in risk adjustment and incorporating the social drivers of health, coordinated referral between primary and specialty care. And yes, we recognize that not everyone is able to do some of this stuff, so continued assistance for small practices. These are some of our messages. In the next slide, we'll begin to wind down. This is the original article a few years ago. If you're interested in more details and expansion on what I've presented so far, it was a Health Affairs Scholar. It's had an awful lot of hits, 10,000 or something running. One of the highest ones, I guess, were informed from Health Affairs Scholar. So it began to resonate with people. These are the group of 8. We lost Gail Walensky, sadly. She passed on about 6 months ago, but she's been replaced by Dr. Lucy Xenophon, which I'll talk about in a minute. The next slide. And here we are. This is our group. George Halverson ran Kaiser Permanente and many health plans over the years. My academic colleague, Richard Scheffler, has done a lot of work on hospital consolidation. I'm there. That's a misnomer. It's not George Halverson. That's Peter Wadsworth, the gray-haired guy. He's an investment banker. He funded some of the early HMOs. He's now in Boston, really interested in patient safety and outcomes. John Kingsdale set up the Massachusetts Health Exchange. Some of you may have heard of him. And the Obama administration based their work, the national exchanges, on John's work in Massachusetts. Allison Schwartz ran for governor of Pennsylvania. She did not win, but she did represent Pennsylvania for many years in the House. And then she headed up the Medicare Alliance and now is a key member of our group and does some consulting. John Toussaint ran a health system, internist by training, ran a health system in Wisconsin, and then set up Catalysis, National Quality Improvement. And he's chaired the board of EPIC and remains on the board. We need to update Gail Walensky. I think everybody knows Gail, really a great contributor, sadly passed on 6 months ago. And we need to get Dr. Lucy's photo in there. She's an internist and radiologist and a continuous quality improvement person. So this group, we meet every Friday, every other week, and we bring in others and we push the agenda along. Next slide is the last one. I want to thank the people who have supported our work so far: American College of Surgeons, Health Transformation Alliance, Kaiser Permanente, Blue Shield of California, the Jewish Healthcare Foundation, and the Gordon and Betty Moore Foundation as well. And so with that, I think that's the last slide. If we can, we can open it up, begin to open it up, Ken, I think for Q&A. Yes, yeah, thank you very much.
Great, thanks, Steve. That was really terrific. Thanks very much. And thanks for all the effort and leadership you've provided to this over the past years. So I'm going to ask the first question, and then I'm sure we'll have lots of questions from the audience. So I've followed the Commonwealth Fund statistics for years. They've featured in many of my presentations. And on a relative basis, I mean, they may change, from metric to metric, but on a relative basis compared to the other OECD countries, they don't change. They either sort of stay the same or they've actually sort of gotten worse. So given those numbers that you presented, those problems and failures you presented in the first 5 or 6 slides, and given all your experience over so many years, why do you think it's become so difficult to solve these problems in American healthcare?
Yeah, it's a great question, Ken, that we all ask ourselves. And my own take on that would be, I think, along the following lines. One is a lot of people, a lot of organizations have their finger in the pie. It's an important pie. It's their business models. It's their livelihood. We do not have a centralized government in the UK, for example. So we have these 50 states. We have multiple commercial plans. We do have Medicare, of course, but other than that, multiple commercial plans, and they vary sometimes state by state as well. And so I think its complexity is part of it. And part of the challenge is, how do you weed out what I'll call unwarranted complexity, right? So we have like pharmacy benefit managers, PBMs. We have management service organizations for medical groups that can't manage themselves, so they contract it out, right? We have a lot of these intermediaries in our system. So that's one. The second thing, Ken, I think is payment, pure and simple. It's that fee-for-service payment system that is just doesn't get us where we need to go. And in our heads, we kind of begin to recognize that, but change is difficult because some people, maybe a lot, are still getting rewarded through the fee for service. And that's why we place a lot of emphasis on that. And the third thing I would say in terms of affordability, the prices are high. The prices are high. I mean, part of that's the fee for service system and so forth and so on and so forth. But yeah, we do have high prices. So I think it's a combination of complexity, payment, prices, and so on That's why we don't make more concerted progress and lift ourselves up in these Commonwealth reports, for example, or the Commonwealth studies.
Great, thank you. So let me turn it over to Kristen now to ask the questions from the audience, which I see there are perhaps 10 there already right now. Kristen?
Kristen, you're on mute. You're on mute, Kristen.
We do. We have a lot of questions here on a diverse topics. So maybe first we'll start with one of the early questions here. Interesting, like if we think about quantifying the value of improved healthcare, that's done in economic terms, improved labor productivity, improved workforce participation to motivate public and CMS health spending. Is there concern that AI, you mentioned AI a couple times, Stephen, and kind of the opportunities there, but is there also concern it possibly decreases the size of the workforce in the coming decades, thus decreasing the ROI on improving medical outcomes, less motivation to focus on healthcare quality and access? So I agree there are humanist reasons to still invest, but we have a focus on purely economic rationale in this period.
Yeah, I think examining the impact of AI, artificial intelligence, and the return on investment and where it can make a difference, it deserves an awful lot of attention. And we need to pay attention to the downside as well, the errors that can be produced and so forth, and what it's going to mean for the healthcare workforce. In some cases, it will replace certain people, particularly in some of the administrative tasks that can be done now by AI, and you don't need some of the billing people and so forth and so on. And so there's no question about that. I think a key is going to be focus and the governance and discussion forums that hospitals and health systems and adopters of AI, along with the generators, need to be a part of ongoing discussion about the pros and cons up front. And some of the ones that we know about are doing that. Mayo Clinic, for example, Cleveland Clinic, others, Kaiser, for example, have people around the table paying attention to that question, for example. And then another element, I think, is what is your measure of health outcomes? Okay, so it depends in terms of return on investment. How are you going to measure the return, right? What are the measures you're going to use? Are you going to use quality adjusted lives? So we're extending lives, quality adjusted lives with better care, etc. Keeping people out of the hospital so they don't get sepsis and an infection, right? So those are the kinds of things I would look at in terms of the return. You're keeping more Americans healthy longer, and you're spending money more wisely than we are now to do that. If you want to encapsulate that, I would say something like pay for smart care, not more care. Pay for smart care, not more care. AI's potential is helping us deliver more smart care.
Thank you. And also thinking kind of on economic terms and maybe in terms of the partners, you outlined kind of all the partners that you've been working with and trying to engage on these issues. And we had an attendee asking if you could comment on the role of private equity on healthcare delivery in the US.
Oh boy, yeah. So my colleague Richard Scheffler is doing a lot of work in that area, and he's a member of our group of 8. So well, first of all, the evidence suggests that private equity has not had a positive impact on U.S. healthcare. It's raised prices, and quality is a little bit. There's some indication it's lowered quality, but that the evidence for that is more muted, shall I say, right? So a lot of people I know say you got to get private equity out of healthcare. I'm not one of those. There's always variance. There's always a distribution. And so in terms of these private equity firms investing in healthcare, giving them resources to do some of the good things we just talked about, I think some are like good characters, good organizations. They're not there for the short-term flip after 2 or 3 years, unlike the Stewart situation in Boston, Massachusetts. They're there for the longer run, right? And so I think you need to be very careful about looking at private equity in a more nuanced way. Now, these states, some of the states that are instituting these spending growth targets, they are also developing merger and acquisition guidelines to analyze private equity and related purchasers, consolidations, and so forth. So they have various criteria that have to be met in order for that allowed to go ahead. And if they're not met, then it's squashed. That's happening in California and a number of other states as well. So we will see. The private equity story is still going to play out.
Also thinking about some of these players, Stephen, you mentioned Medicare Advantage, and you kind of alluded to this a little bit in your presentation. We had an attendee comment that some of these plans have demonstrated abuse, and what can be done to make them more reliable before you recommend them.
Yeah, so a lot of that was the upcoding, and that's been largely fixed now. They're using actual encounter data to do that. They're also working on the fee schedule and how that is determined and so forth and so on, because it's based on traditional Medicare fee for service to begin with. So those are, some things that are going on with Medicare Advantage. Most of the studies I've seen actually show a higher quality of care for patients choosing Medicare Advantage. Now, you can argue that maybe they skim, et cetera, but there's ways to control for that. It's still, ongoing study, but I think now about 50% of Medicare is choosing Medicare Advantage over traditional Medicare.
Great. So we have another attendee who commented about kind of the data that you present shows kind of the value of the risk-adjusted payments, but there's been low adoption. Do you think this hesitancy is driven more from providers or also maybe on the payer side, some hesitancy there? And whose incentives are counter to this method? I imagine that fee for service is more profitable for providers. What will move the needle for providers?
Yeah, no, that's the nub. That's the problem. It's both. It's a relationship. It's the plans and the providers. And they basically point the finger at each other in different ways. The provider organizations say that the health plans don't give them timely data, turnaround, et cetera, or they have different requirements for the data, et cetera. And so we're beginning to work on standardizing and making it easier, reducing the administrative burden on provider organizations to submit the data to the health plan for calculating scores for quality and so forth and so on. The health plans, on the other hand, point to the providers and they say, look, you're not giving us the data in the right way, et cetera, et cetera, et cetera. So we're working on all of those things. And California IHA is a great example where we have all those parties around the table and they're working together collaboratively to improve that. So part of it is a big data flow, accuracy, and timeliness of data between providers and the provider organization networks and the health plans. Part of it also is as you move towards capitation risk prospective payment, you have to redesign all your software because you're no longer submitting claims for each fee and because you're capitated up front. And yet you need to get some data to do other things. So some of it is rejigging the software and the computer systems to move to full risk adjusted prospective payment. That doesn't happen overnight, takes time. So these are some of the reasons the providers and the plans both, it's going slow. It's slow slogging in many respects.
Maybe we'll take one more question here. I love the data piece. We had another question about, the importance of data. But again, like to kind of this idea of it takes so many partners. We had a question here about, what do partners like from biopharma, or if we talk about medical devices, what are those kind of industry folks? What role do they play here to advance those goals?
Yeah, that's a great question. I should have indicated at the beginning, I'm happy to, I didn't address pharma or biotech or digital health as such, other than a little bit on AI. Happy to do so. Also, if people have a question about the Medicaid cuts, it looks like they're looming, from the administration, I could comment on that too. But let me just address this question. The supply chain, absolutely. Once you move the provider organization to a health budget, like Kaiser Permanente or whoever's perspective, right? They have every incentive to work with their suppliers now, the supply chain, to say, look, here's the situation. We can give you a lot of business. Here's our budget. We got to negotiate the prices here, right? And so it's a negotiation, as it were, with pharmaceuticals, et cetera, et cetera. If the government's not going to step in, although it's trying to reduce it, then the big health systems have to try to do what they can by offering volume, and say to pharma that, look, for us, let's 20% reduction, right, for our provider networks and so forth and so on. And then in terms of digital health, telehealth has great potential, absolutely, and other forms of digital health as well. Those are going to be part of the toolkit, but you have no real incentive to use these new tools and innovations unless you have some resources, predictable resources to do it. If you're, on fee for service, oh my, et cetera, I got to generate a margin here, and maybe next year we'll have enough to, switch to this or that or the other thing coming down the pike. The other element of this is some of the academic medical centers, all kinds of new technologies and therapies coming down, and CRISPR and so forth, how they can work with health plans to build those in prospectively so that the hospital or health system isn't left holding the bag for the new thing that just saved 5 or 6 lives. Are the plans willing to go at risk with that health system to say, let's measure this, we will include that in our premium rate because you've given us the data that you're going to have 250 patients using this technology, and we'll work out a way of paying for that so they get it. Some of that's beginning to occur as well.
Great. Maybe I'll try to squeeze in one more real fast here, Stephen. For some of the ideas that you've talked about here today, we had a couple of questions around just kind of looking outside. Like you talked about how we rank kind of globally in terms of, the outcomes that we see here in the US for the high costs. Are there examples from the Canadian healthcare system, from other countries kind of higher up the list, and some of these things that you've talked about here today that we can really kind of look to globally for ideas to bring here?
Yeah, that's a great question. The short answer is yes, we can always learn from others. Part of it is they tend to streamline the relationships and the transactions between payers and government and the patients and those who provide the care. So that's one thing. A second thing is they tend by and large to perhaps have fewer or less complex rules and regulations governing behavior. Like we have this prior authorization stuff, which I didn't talk about, but could. In other countries, most of them don't have that, okay? So, and we're trying to fix that, of course, as well. So those are some of the things we can learn from other countries. Other countries, UK, they also have national technology assessment centers. As new stuff comes along, they do the cost benefit analysis, the risk-adjusted lives, quality of lives, et cetera, before agreeing that they're going to pay for it. But they're paying for it, at the government level or whatever. It trickles down then for those that use health plans, Germany, the sickness funds, for example. So those are some of the things, but we have different culture in this country, and we're not Canada, we never will be, and we're not the UK, but that doesn't mean we can't learn from them. And one of the things we can learn, continuous quality improvement. The catalysis does a lot of great work in Europe, and then the UK system in particular, they've been doing great work. And we can learn from some of that. They're also working here in the US, of course, as well. And one of the things to recognize about the Commonwealth thing, it's a ranking, right? So it could be that even though we're 12th, we're not that far off, maybe 8th, you know what I mean? It's a ranking, not a statistically significant difference in that specific measure. But when over time you're constantly in that lower quartile and whatever, others are continuing to improve, maybe we are too, but we don't jump over anyone. It's cause for concern. It says there's something here. Now, in terms of some care management stuff, we're actually second. That's about the only one of their 16 or so measures they have where we score high. We're doing some good work there. We do good work around cancer care now, heart disease to some extent, but on all these other measures, we're near the bottom.
There's a lot. There's a lot of
And there's a lot.
opportunity, I think, as people here know. So maybe we're at the top of the hour. We'll close out our session for today. And I'd like to give a big thanks to Stephen Shortell, to Ken Kaufman for joining us. To our attendees, it was great to have you here today. Maybe I'll see if my colleague in alumni engagement can share. I had a few links to share. We'd love to have your feedback about today's event. And you're welcome to sign up for the Healthcare Initiatives newsletter if you'd like to keep in touch with healthcare happenings at the school. We have a Booth Industry Insights event on healthcare coming up on May 27th. The Harper Lecture will be on healthcare on June 5th. And in the meantime, I hope you all will join us in the healthcare community on the new Chicago Booth Connect platform to keep the conversation going. So thank you all.